Hi there everybody, welcome back to the channel. This video, as you're seeing it, has been scripted in the early hours of the morning of the 4th of June, prior to the formal publication of the Leng review in 2025. Some early leaks are now starting to emerge from various press outlets, and basically I want to try and document my reflections before any official findings land, because people have been asking for a summary of what's been going on with Leng. There's some important contextual stuff that I want to talk about, but as always, especially on videos like this is a space, and the comments here are a space for calm, reasonable, rational discussion. No name calling, no heckling, thoughtful engagement. I do not normally get involved with moderating too heavily, but any abusive comments in the comment section of this video will be manually deleted. For those unfamiliar, the Leng review is an independent inquiry led by Professor Gillian Leng, who is the former chief executive of NICE. It's commissioned by the Department of Health and Social Care, essentially to examine the safety, effectiveness and potential future roles of physician associates, PAs, and anaesthetic associates, AAs, within various settings and multidisciplinary teams throughout the NHS. It is fundamentally a review of whether these roles are working in practice, what people are actually doing, and how these roles may be integrated or not integrated into clinical services and what patients need from the NHS. And this process has involved a few different things. There have been some stakeholder webinars, visits to clinical sites, patient focus groups, a large-scale call for evidence, all of which Prof. Leng will consider, put together, and come out presumably with some number of recommendations as part of her report. I actually attended the resident doctors stakeholder webinar myself. I asked a question about scope of practice and training. That was answered by Prof. Leng. Although at that time I didn't find the response I received to my question fully satisfactory, and I still don't, so I'll come back to that a bit later. But importantly about these webinars, all 5 of them, I think there are 5, are now published. There are links to all of them on the Department of Health and Social Care's YouTube channel, so you can actually go back and watch. There was one that was done with PAs, there was one with resident doctors, one with anaesthetists, and so on. Now coming back to Prof. Leng herself, she has presented herself very well, I think, throughout the process as very methodical, evidence-led, open-minded. Her analogy that she used was this idea of walking a tightrope that came up in, I think, all of the webinars. She is navigating a very heated and complex issue. She appears to be trying to do so impartially, and personally, I'm going to put my hands up and say, I believe she herself is sincere in her approach and committed to a sense of objectivity, but the reality is that she has been given a task which is thoroughly unenviable, I think it's fair to say, and the outcome, or her findings, or whatever it is she reports, will almost certainly disappoint at least one stakeholder group. Probably, I suspect, disappoint everyone, because there are some positions involved about scope of practice in the deployment of medical associate professionals, a few mutually exclusive positions, right? So almost certainly not everyone is going to be happy. Now, collating everything thus far from the webinars that have now been published and all the material that we've seen, from my perspective, I want to be clear about that, several repeated issues I think are starting to crystallize out, and this is what I expect her report to talk about. The first is clarity on scope of practice for medical associate professionals. That is an umbrella term for PAs and AAs. Clarity as to scope has been pretty much universally raised as a concern, because the roles vary significantly across different trusts and departments, and there is a lot of inconsistency there, and that is fueling a lot of mistrust, a lot of potential risk, and obviously that makes doctors uneasy, because if I'm responsible for supervising a medical associate professional or working with them, if the roles are so sort of poorly defined that you don't know what training anyone has or what they are competent to do or what they do and don't know, then that introduces a lot of uncertainty for working with them and taking responsibility for them. Equally, if I were myself a PA or AA, I think I would also find that very troubling, the lack of clear scope of practice because scope of practice is part of your professional identity, right? And it defines what your role is, how people understand and relate to your role, what activity you may do or not do day to day, what you might expect to do one day. All of this stuff is very central. The next one is supervision, because in practice, supervision for MAPS is very poorly defined. Levels of supervision have been shown to vary between trusts, between different consultants, what they tolerate. If it's a GP in primary care, supervision to one GP may mean debriefing after every single patient. Debriefing might mean one afternoon a week where you talk about all the patients you've seen. And again, coming back to clarity, I think clearly most people agree that this must be addressed. Then I want to touch on the title itself, and we'll talk about it more in a bit, but public and professional understanding of the title physician associate in particular. There is a lot of reported feeling that that title is confusing or not well understood, that people particularly don't understand that they're not seeing a doctor. And this is something that Prof. Leng herself has reported that is probably the most common theme that's come up, and it's been the feature of several coroner's reports now after there have been some very unfortunate deaths. The title has also been specifically picked up on. Then thinking about medical education, so for someone like me starting my specialty training very soon, there are often raised persistent concerns that MAPS are sort of taking over service delivery functions in ways that then reduce learning opportunities for doctors in training. And then you might think about policy direction as well. Some stakeholders throughout this whole process have seen the expansion of PAs and AAs as something that is pragmatic, that is necessary, that must logically happen if the NHS is to continue to exist. On the other end of that spectrum, you've got some people who view it as unsafe substitution and a threat to professional or clinical standards. So that's the other angle from which to consider all of this. So let's talk about scope of practice, right? That's the crux of all of this. If there is a single issue at the heart of this controversy, I think at least it's scope of practice. And it's fundamentally where I also believe, and I'm saying this is my belief, this is where the rollout, as it were, has failed in the most serious way, because it's become clear both from Prof. Leng's webinars and broader discourse and the documentation that we've seen going way back when, some of which comes from the GMC's own internal documents, that medical associate professionals were originally introduced to, at least in part, substitute for doctor labour in areas where recruiting doctors was difficult. And that is not my speculation, that is what Prof. Leng herself has acknowledged. That's what we've seen documentation of, both around, it's about gaps. Gaps is the word that has been used in either geographic areas where you can't get doctors to work, or there aren't enough doctors working there, or you're talking about gaps on rotas that come from instability as trainees move around or need to cover out of hours, need to cover on calls. So then your core service delivery is more difficult, and MAPS was sort of touted as or touted even as the way to ease up these service delivery problems by taking on some of that work. So it really is at its core about substitution of work, because that framing matters, I think, and I think we really need to be key and honest about that. If MAPS were designed as stopgaps in, for example, under-doctored areas, then their training should be very, very tightly scoped and linked to very specific, well-defined duties, right? Because they're filling in very particular gaps. But instead, what we've seen is role creep into complex diagnostic and therapeutic domains, independent working without meaningful supervision or scopes of practice that are held by trusts. Trusts very routinely fail to publish these or send them, even when you freedom of information them out. They simply don't have them. As well as thus far no nationally agreed limits on practice at all. I think there was a sense that you would essentially have a sort of pluripotent pseudo-medical workforce that could fit whatever gap you wanted to put them in, and therefore it was felt to be unhelpful to constrain the role, because then you'd end up with the same problem of not having enough people, as we can all understand. having a very shortened, abridged, superficial training program is not the right way to make expert generalists, right? Those two things don't go together. So I then want to talk about this other argument that came up from Prof. Leng herself, from speaking to senior doctors, that MAPS were felt to become the glue, and again that phrase was used, of the clinical team because they specifically don't rotate and move around like doctors do. This was kind of at the heart of my question that I asked, which was essentially, doctors train very long and very hard, and a lot is asked of us, including rotating between hospitals all around the country, etc., to develop the skills that we need for our specific scope of practice, right? Our scope increases as we build more experience and complete accredited postgraduate training programs. I then said basically that's why it's confusing or difficult to see people without the breadth, length, depth of training or the experience practicing often with very similar scopes of practice to us, because we are told that all of those things are necessary, and indeed our colleges and the GMC hold us to those standards. That's why it's very hard to see those scopes of practice and that work being done by people with significantly less knowledge and experience, and that's, you know, the fundamental reality of the matter. So coming back to this, because MAPs don't move, they act a bit like a glue in the clinical team and hold everything together. But fundamentally, that's obviously ignoring why doctors are told to rotate, to gain broad exposure, build your broad competence, and ensure safe generalist from all of the rotations in different departments and specialist practice. So I'm about to start training as a neurosurgeon. The very minimum that I was expected to have was my medical degree, which was 4 years after my bachelor's, but is normally 5, plus 2 years of foundation training, where you must, to fulfill the program, spend 4 months across different areas: community, secondary care, medicine, surgery, mental health, primary care, all of these different things. And that is the absolute minimum necessary in order to be allowed into higher specialty training, because that is the minimum to give you your generalist exposure to safely manage medical patients independently. Now, obviously, MAPs don't have that right now. There is no model that gives them that experience. Their graduating degree, the qualifying degree, is significantly reduced. Therefore, it cannot be the case that they should be responsible for sort of managing the day-to-day medical patients on the ward or progressing to higher specialist activity in a specialty safely. You can't have that at the same time as you're telling a different group of people that they need to do much more to also get there. And this discrepancy is why I think the scope should be narrower, not broader. And I don't think many people could object to that. You can't have both worlds, where a MAPS scope expands without them moving anywhere. It's able to expand specifically because they don't move and the department invests in training them. But then a doctor's scope can only expand by moving when the doctor comes from the broader base on which to build more training, which is something that Prof. Leng herself acknowledged. But when I pitched my question, also wasn't able to make these links or connect these things together, and I found that a little bit disappointing. There's a massive double standard that's being overlooked there. So in effect, we're allowing some practitioners to do parts of a doctor's job, or in some cases all of a doctor's job, without the equivalent training, supervision or accountability, and we're doing it potentially the most often in areas that are already disadvantaged by staffing and geography. And that risks a very two-tier system of care, where those in need receive the least qualified staff, which is the inverse care law that we often talk about. That should alarm us. And that's of course not a MAP problem, that is a government obsessed with providing cheaper care problem. But going back to what I was saying before about the reasons why the MAP roles were developed, if you're specifically thinking and struggling about those hard to staff, undesirable, more deprived areas, that is the last place in the country you want to be putting people with less training as medical substitutes, because they're gonna have worse health outcomes anyway. You need to be doing the opposite and pumping more money into those areas such that they can get doctors. What I think I struggle with is how the public health big bods and policy wonks are able to unify this idea that a bum on a seat is better than nothing, essentially. Well, we can't get doctors, so let's put something there that looks a bit like a doctor but doesn't have the training for the poors, essentially, or the least affluent areas, or those that are more rural and out the way. That, to me, just doesn't gel. I don't know what we do about that. Then we need to talk about the name more specifically, because as of the 4th of June, that's today as I'm recording, there have been some leaks to the press suggesting that the title Physician Associate, which is a current title protected in law for PAs, is likely to be dropped. Now, Professor Leng herself was notably very frank in the webinars about this recurring concern. I myself was surprised by how forthright she was about that. She was very clear that this had been a recurring concern from lots of different stakeholders. What do I think about the name? It's not something that I've talked about extensively. I think Physician Associate, for me, does lack clarity, because it doesn't really tell me anything about the role other than it is associated to a physician, I guess, a doctor, but I think it can be interpreted by patients and even staff as synonymous with doctor or someone who is similarly qualified to a doctor, obviously neither of which are true, and I would hope PAs themselves would recognise that that's not true. They're different jobs and different training pathways and different roles. What might the alternatives be? It could obviously revert back to physician assistant simply, or something like doctor's assistant I've also seen tabled. Those I think are clearer, albeit not potentially palatable to all stakeholders. And it's worth recalling, actually, on that note, that the Department of Health specifically intervened to recommend removing assistant from the name, in part to improve professional perception and support for regulation. And that, I think, speaks volumes about the political calculations that are going on behind title choices, rather necessarily than patient clarity. And Jeannie Watkins, I think it's a quote of hers, who was one of the early more visible PAs at the helm of the profession, made a public comment about removing the handmaiden, sort of servile, subservient connotations of the name assistant. And actually, I think this really is still the thing that needs to be decided, really, as the role is likely to go forward. And I'm going to predict that now. I think the role will stay, as well with AAs. I don't think Prof. Leng will recommend abolishing either role. But the question is what does the NHS need? And particularly if doctors are going to be taking on a lot of supervision burden, what do they themselves need? Because I think a lot of doctors would like a doctor's assistant. That would actually make them much more efficient by giving them tasks that don't require their training. But fundamentally, that's obviously not what's happening here, because the way that the PA role seems to be sort of designed at the moment is taking histories, doing exams, coming up with management plans, performing specialist procedures and things, all of which are the things that do require a doctor's training. So you're not allowing doctors to practice at the top of their license, or whatever phrase is normally spouted, which I don't believe, by the way. And the reason I don't believe it is there's little to no effort to ensure that doctors are able to practice to the top of their license in any other setting. Administrators are being pulled, theatres are massively inefficient, doctors are doing all their own training, leadership development, portfolio stuff. They don't get support for any of this stuff that would make their roles more efficient. So I do not believe, basically at this point, that doctor efficiency and PAs right now are related. It's simply a line that I don't buy. And as we move towards the end, I think a note on transparency, and this is one of the reasons why I wanted to get this video out before the report publishes. It's worth mentioning, and Professor Leng herself acknowledged this, and this needs to be talked about more, at least one hospital during the site visits that she did deliberately did not inform their resident doctors that she was visiting the hospital, clearly to avoid poisoning the view that might be presented to her if resident doctors were charged and not in favour of the role. And I just think that is extraordinary, like that is a thing that happens. It is an absolutely dismal failure of leadership and accountability. It speaks to a wider culture of opacity that has surrounded the map rollout, and again, that is not a comment on the maps themselves, but the execution of the rollout and expansion has been horrendous. Because as someone who has now done 3 or 4 like commercial standard leadership programs, I do not know what model of leadership these people are subscribing to, but it's pathetic. It is absolutely pathetic. Then thinking about potential outcomes, will we see anything about pay inequity? I actually want to be pretty clear on this. I think I may be a bit of an outlier. I do not, hands up, believe that PAs or AAs should have their pay cut. That's not a solution that works for me. I don't think that's the answer. But at the same time, I do not think we should accept a situation where a new doctor with more training and responsibility at graduation is paid less. Like, that's also ridiculous, and I would think that both of these things can be seen together. Then F1 doctors, a newly graduated doctor, could simply be uplifted to band 7 equivalent pay with proportional adjustments above the grades, just lift everyone up. That, to me, is the basic question of fairness and retention. So coming to a close, what do I think the review will ultimately recommend? Name change? I think that is very likely on the cards. To what? I do not know, but I think whether it has assistant in the name or not will be one of the sort of landmark things that comes out of the review. Pay changes, I think unlikely, probably not within scope, given that the review was about effectiveness, but I do think that the current pay inequities are unsustainable, particularly at a time where doctors are balloting for strike action again. And then the last bit is scope of practice recommendations, because here I've become much less certain again. Professor Leng is a public health consultant. She is not a clinical subject matter expert in anaesthesia, in emergency medicine, general practice, any of these things. And while therefore she can comment on safety and current practice, you know, she's been around to lots of places and she can report on what she's observed, I do not think she will prescribe detailed scope recommendations, and nor should she, in my view. That must come from the Royal Colleges and the specialty bodies, because they're the only people that have enough of those subject matter experts. And I do know, again, some of the Royal Colleges waiting on publishing about scope recommendations until Jill Leng publishes. Cowards. You set the standards as the specialty bodies. You do not wait for someone who isn't a subject matter expert to tell you what to do. Publish your scopes. But what she can do is highlight variation, identify areas of concern, and recommend frameworks for defining and monitoring scope nationally. That is what I think she could do. The colleges themselves are the experts in setting what will become clinical role boundaries. That has to come from specialist societies and colleges. But if she were to recommend a framework on monitoring and implementing those scopes, then I think that would be a good outcome of her report. I'm sure that this has been a difficult process, both for Prof. Leng, for all of the staff groups involved. The anxiety and division between the different roles are really stark at the moment. Lots of people are out of work because of national workforce planning failures across the different roles. And again, there's nothing more to it than a devastating failure of leadership. I do hope that we can separate systems level and leadership level failings from individual professionals within struggling professions, because I don't think PAs and AAs are the enemy. It's just not a line that I think is helpful. Those enabling poor practice, poor communication, weak governance, lack of transparency, those people are enemies and should be identified and removed from their positions of leadership as quickly as possible, because the well at the moment is poisoned, and until you find out the people that are continuing to poison the well through bad practice and get rid of them, then nothing's going to change. If the Leng review provides a springboard to correct those mistakes through clarity, regulation, interprofessional and inter-role collaboration, then it might be a positive turning point. But that is it. Thank you very much for watching, ladies and gentlemen. This was quite cathartic, and I would love to know what you think. What are your predictions for what Prof Leng is going to publish? I would love to know down below. Take care. I'll see you soon.